Fantastic. So it's a pleasure to be here amongst many friends and colleagues today. 7 minutes. Thank you. So, there is no doubt in 2025 that intravascular imaging will improve both procedural and clinical outcomes. You will never see a calcium talk without talking about imaging every single time. You're more likely to recognize significant calcification and to recognize the need for advanced lesion preparation. You're more likely to choose the right equipment and the right stent size, both length and diameter, and you're more likely to optimize post-stenting and recognize complications. All of this gives you a bigger stent, better expansion, better diameters, less complications, and better outcomes. And the name of the game here is consistency. If you do the same thing every single time, you're likely to get the same result every single time, or as close to every single time as possible. So, looking at the steps, we're all aware of MLD max. We're just going to go briefly over a few things. Pre-PCI, is there calcium? Where is the calcium? How do I best treat the calcium? During or post-lesion preparations, have I done a good enough job? Can I safely proceed with stenting, or do I need to do more lesion preparation? And then post-PCI, do I need to optimize more? Do I have any complications I have to deal with? So here's a couple of quick cases. This is a planned PCI to the right coronary artery, and as you can see on this OCT, there's an arc of calcium, a 360-degree arc of thick calcium. And as we look more closely, we can see a cushion, a nice little cushion of softer fibrotic tissue. And this is so the calcium is 2 millimeters away from the lumen. And this tells me that if I took a rotablator, I'm not really going to affect this calcium. I'm going to rotablate the cushion. We're not really going to modify the calcium. This is best treated with lithotripsy. The fact that there is a cushion there tells me that it's going to be easy to deliver an IVL catheter. The next step is to plan our procedure. How big is the vessel? Where do I start? Where do I finish? Where is the calcium? So you can look on your co-registration. It's a 3-0 vessel. We know where we need to start. We know where we need to finish. And we know where to focus our calcium management. We're going to spend a lot of money on our balloon or whatever we're going to use. So we need to focus all of our efforts in the specific place where it gives us the most bang for our buck. Once we've done our lesion preparation, we've chosen the right IVL balloon, the right NC balloon, we go back and we re-image to make sure that we prepared the lesion. You can see in both axial and longitudinal views, we've got multiple fractures alongside the course. We are ready to proceed with stenting. Once we've stented and post-dilated, this is a very good angiographic result. Normally, we're quite happy to walk away from this case feeling very good about ourselves, but as we re-image, we realize that there's a segment of under-expansion. And this is an eccentric disease, you might not see it in all angles. There's one area there that needs more work. And you've got co-registration that tells you where to focus with your optimization post-PCI. So you go back, you optimize at higher pressure, you either use a bigger balloon or use the same balloon as I did, but at higher pressure, and you re-image and you ensure they've got good expansion with no dissections or complications, and you've got a very good angiographic result. In truth, the angiographic result doesn't look much different, but now you've got more confidence that you've got a better job. Our second case has got the severe LAD lesion. You can see here we had to use a Guidezilla to deliver the smallest semi-compliant balloon, and even that wouldn't dilate. We couldn't deliver anything else. We barely managed to shove the tip of an IVUS catheter in there, and you can see a very thick ring of calcium that is quite superficial. So this is the perfect case for a rotablator. So we took a 1.5 millimeter burr, as you would. But after we rotablated, we tried to use our balloons, and we still couldn't dilate it appropriately to get a good luminal gain. Now in the old days, if you go back 10 years, you use a bigger burr. But these days, I almost never use a burr greater than 1.5 millimeters. Because why? You don't need to. It's safer to use something else. This is where I'd like to use a RotaShock or an IVL guided therapy. And as it was mentioned by my colleagues, you can use stent boost technology to locate where your emitters are and place them right next to the calcium so you get the most bang for your buck. And then you follow with an NC balloon and you re-image. So as we go through the IVUS here, we start to look for whether we've done a good enough job at preparing this lesion. And as you can see here, there are fractures towards the left, there are reverberations towards the right, and a nice little hematoma to show you that you've caused a therapeutic dissection of the vessel and you're now ready to stent. We can see on the longitudinal view that we've got fairly good luminal gain. I think we're good to go in terms of stenting. So we stent, we optimize, we post-dilate, and we re-image again. That same segment that had a very critical bit of calcium has got a stent area of 10.5, very good. We looked at our expansion, there are no edge dissections and no complications, and an excellent final result. So to summarize, intravascular imaging improves both procedural and clinical outcomes in severe coronary calcification. If you take a standardized approach, you're safe, you're consistent, and you have reproducibly good results time after time. Know your enemy, know yourself, and then you can always have a good outcome. Thank you.
Thank you.